and thank you for agreeing to answer some of these questions. You mentioned that you've had to make a lot of changes to the clinic during COVID-19. For example, using telephone conversations and video consultations. Do you think that some of these changes will or should be permanent? And how do you think this will affect your clinics in the future?
So yes, it's a very important question indeed, particularly during these times. We have changed clinic practice significantly. We have moved on to, as you rightly mentioned, video and phone consultation. We've tried to make this as standardized as possible, given the fact that we're all very new to it. With regards to video consultations, I have to say it has been used much less in CLL than in some of the other blood cancers. With CLL, in majority of the cases, it has been phone consultation, even when it was the first time the patient was being informed about their diagnosis. But we've done a few video consultations as well. The video consultations are done in the same line as GPs have done their consultations with patients, where the patient is given a specific date, time, a particular link to join in. And it is imperative that the patients have access to internet connection, computers, laptops, wherever they would connect. And they are encouraged to have a family member attend the consultation. With regards to phone consultation, there are many variations in how consultants offer phone consultation. So whether, I mean, in order to answer your question as to whether these consultations are here to stay or not, it's difficult to comment at this point of time. But like any system, any new system within NHS, it does have its pros and cons. There are risks and benefits. I think one has to be one has to bear in mind that apart from reducing the risk of COVID exposure, phone consultations come with a lot of other added benefits, such as avoiding a trip to the hospital, taking time off from work, booking the time off as leave. It kind of avoids parking hassle, which I believe is a major issue with many trusts around the city. And obviously for patients who've got physical disability, they can avoid that trip. For physicians, of course, it enhances their workflow and improves efficacy and efficiency in a more timely manner. But the kind of reservations remain about that, every consultation is carefully documented. For something more traditional way of information gathering, such as physical examination and nonverbal cues, we might miss out on those. So it is perhaps doubly more important to ask about any lymph nodes they might be feeling. Are they having an increased satiety, as in early satiety? Are they feeling abdominal fullness, dullness? Can they feel a swelling in their abdomen? Things that we would normally perhaps examine in a regular appointment, we're now having to rely particularly more on patients' ability to mention them and perhaps to identify them. And also saying that, because of the community we practice in, we have to consider patients who have got language issues, communication issues. English may not be their first language. Even family members they live with may not be able to communicate well in English. So that might be very difficult for them to do a phone consultation then, and particularly patients who've got cognitive impairment. So yes, there are pros and cons, and personally, I feel that particularly when there is a pandemic on, phone consultations have been life-saving. And more and more, we've inclined towards phone consultation with CLL patients, but you have to have that reservation in mind that for a specific cohort of patients, you're probably better off bringing them in the clinic for a face-to-face appointment.
Some patients, of course, will have to go to the clinic for various reasons. Are you able to reassure those patients that a visit to the clinic today is safe, or as safe as possible?
I'd like to say that we are still in the process of doing our absolute best. Hospitals across the country have ramped up their safety procedures. Trusts have shared images on their social media website, mentioning all the precautions they have taken to keep patients safe, such as social distancing. They have put markers on the floor, so their individual spaces can be respected. Also, there are fewer people allowed to sit in the waiting room. There are 2 chairs gap in between each patient sitting and waiting in the waiting room. We've got specific staff employed just for the purpose to ensure that social distancing is maintained. And with all these measures put in place, I would want to reassure patients that if your physician has thought that there is a need for face-to-face appointment, we will be doing our absolute best to make sure that you're safe.
Thank you very much indeed. As you can imagine, a lot of the questions that we're getting are about the easing of lockdown. Should we, as patients, be contacting our consultants to ask about personal risk, or is that just my own assessment? In other words, how much can a patient judge how far they progress with lockdown?
Very important question, but very difficult to answer at the same time.
Of course.
Because the rules for lockdown, I mean, it was perhaps more easy when it was a one rule for all, as in generalized lockdown and generalized shielding. But since the relaxation of the lockdown rules, I would request patients to go onto the government website. And just to briefly touch, you've got the extremely vulnerable and the moderate risk group. Extremely vulnerable are patients who are on treatment, and moderate risk group are those patients who are above 70 and have any other comorbidities. Now, my general rule of thumb is if a patient with CLL is stage A, and they're not on any treatment, they're on watch and wait, and they're otherwise fit with no other comorbidities, then they are probably okay and at the same risk as that of the general population, and don't need to do anything extra in terms of protection other than what the general population is already guided to do. Whereas for those patients who are on treatment or are at a stage where they will be needing treatment, it's impending treatment in future, I think it's best to be safe. So usual social distancing measures, sanitization, work from home, and if you do have to go to work, make sure it's COVID safe, avoid travel, avoid contact with grandchildren within enclosed enclosures, avoid flights and hotels. I think those kind of rules generally apply. But if you have any specific question associated with your disease per se, and you can't make your mind up as to how the COVID and the disease interact or associate with each other, then I'm sure your clinical team will be more than happy to take those questions.
Yep, thank you very much indeed. Next question is, are blood cancer patients at a higher risk of COVID-19?
A very interesting question, Brian, and I would like to quote a publication that's come out just early this month. Not this month, early August. We're on the 1st of September now. And this was a study which was done by the University of Oxford and Birmingham together. And they were kind of registering data of all patients with cancers, their age group, their comorbidity. And interestingly, what they have found is that patients with blood cancer, although at this point they have not quite alluded to the specificities and the specific types of blood cancer, but generally, patients who have blood cancer are 57% higher odds of having a severe disease if they contract COVID as opposed to other kind of malignancies. And the other contributory factors they have found is age and comorbidity. So the answer to your question is yes, if a patient has blood cancer, they are likely to have a more severe form of COVID, more so if they're elderly and have got other comorbidities.
Thank you. That goes back to your previous answer, which is for CLL patients to take greater care. It really comes down to that, I guess, in the end.
Absolutely.
There's a question here about, I think you may have already answered this one, but this person is on watch and wait. Do we know if CLL has been recategorized? Because she's had a letter which says that she's now of moderate risk rather than at the higher risk. She thought previously that she was in the high risk category. She's a CLL patient on watch and wait.
It depends on her age, and it depends on her comorbidities.
Right.
Now, by virtue of being on watch and wait, and if she's above 70 and if she's on has comorbidities, then currently she would be under a moderate risk category rather than we're not calling it high risk anymore, we're calling it the extremely vulnerable group. So given that new categorization, she'll come under moderate risk.
I think this is a question that someone else gave us last time, but it's if I am unfortunate enough as a CLL patient to test positive for the virus, what should I do apart from panic?
Um, I'd say firstly, I'd say don't panic.
Yep.
Easier said than done. But it's first of all, basically, it's the same rule, which is self-isolation. Try and stay far away from other members of the household to avoid the risk of infecting others. Usual measures of hand washing and sanitization. I would definitely inform the clinical team looking after the patient that they have contracted COVID so they are aware. And then if the patient is on watch and wait or active surveillance, at that point, provided they're otherwise well, no other active measures are required. However, if on treatment, seek advice from the medical team. Generally speaking, if the patients are on active chemotherapy, then the chemotherapy will be withheld at that point in the fear of making the patient any more immunosuppressed than they already are. And withholding chemotherapy for a brief period of time does not alter the long-term outcome significantly. It will be much more important for the patient to be out of that COVID situation first before they can reinstate chemotherapy. In any case, for patients who say are on FCR chemotherapy, we were considering stopping the chemotherapy after they've had 3 cycles. So the point I'm trying to make is that if you're on immunosuppressive chemotherapy, do not worry that as soon as I stop the treatment, the disease is going to come flooding back, because at that point, the priority is getting rid of the COVID.
Surely, yeah.
So, but that should not be a blanket policy. Discuss with your consultant, discuss with your clinical nurse specialist, and I'm sure they will give you guidance with regards to that, because there are so many different kinds of treatment available for CLL. But if the condition gets worse from a COVID perspective, it's the same advice which is use NHS 111 online site. And if you do not have internet access, then call NHS 111. And if it's a medical emergency, then do not go on online sites or call, just call 999.
This is a question from someone who has normally IVIG, and they say for patients who cannot have their regular IVIG treatment because of COVID, they've been asked not to go in. Should they ask for prophylactic antibiotics, or should there be prescribed antibiotics?
So I think with IVIG, a lot of trusts have kind of relaxed their restriction policy. So for example, in our trust in February, March, April, May, we just stopped all our IVIGs.
Mm-hmm.
Now, for those patients who had an indication for IVIG, it was discussed on a case-by-case basis, and depending upon the consultant's discretion from how much benefit the patient was actually achieving from the IVIG in terms of their reduction in infection risks or infection incidences, we were giving them 6 months worth of prophylactic antibiotics. But I have to say, from the end of June, we have relaxed our IVIG policy, and the same applies for monoclonal antibodies such as rituximab. So we have relaxed and we have gone back to our pre-COVID state.
Oh, you have, right.
Patients who are getting IVIG now have started to get it.
Yes, someone's given us a question about Isshingrex. Is it generally available yet?
It kind of varies from surgery to surgery. I've had some GP surgeries who've had problems to procure it. Some places have had it. I think your best person to talk to is your GP pharmacist or your GP nurse specialist. They'll give you the best advice as to whether it's available in the region.
Fine, thank you. Another question here about the difference between CLL and SLL, and is there any difference in the monitoring and treatment?
Yes, so SLL is principally lymph node disease, or where the disease comes in with a bulky liver or a spleen. So for a patient with SLL, their lymphocyte count may not be that high, almost may even be near normal, but they may have bulky lymph node disease, and they almost present like a lymphoma. So which is why we call it a small lymphocytic lymphoma. And in those cases, the biopsy of the lymph gland is the way we diagnose the condition. And we would do a CT scan at the time of diagnosis and at the end of treatment to assess response. Whereas CLL is predominantly a blood disorder, where the main diagnostics is done based on the high lymphocyte count. And thereafter, we response assess based on how the blood counts are responding to treatment. Now, interestingly, however, the treatment for the two remains the same. But if in SLL, there is perhaps a higher or rather to say a lower threshold to consider Richter's transformation. If someone's SLL is rapidly progressing, we would have to have a lower threshold to see whether the patient is transforming to a higher grade lymphoma.
We're all hoping for a vaccine against COVID, but will it be as effective for CLL patients as for the general population?
I wish I had a very clear answer to that.
Yes, quite.
But the answer is it's difficult to say. Generally, with CLL patients, their immune systems is under stress. So they may not mount a similar antibody response to vaccine like the general population. But I think if the vaccine, once and when it's available, I think the CLL cohort perhaps would definitely be somebody or someone where we would try the vaccines. How they're going to respond, whether they respond at the same rate as that of the general population, is only time can tell.
Does the greater risk of other cancers apply more to CLL patients than other blood cancer patients?
Not quite, Brian, because there's never been a head-to-head comparison between different blood cancer groups to say this particular cancer can cause more second cancers as opposed to that. What we do know is that, for cancers such as myelodysplasia or myeloma, some of the agents they get treated with can cause second malignancies later on. Likewise, for patients with Hodgkin's lymphoma who's had radiation therapy are more predisposed to breast cancers, for example, or thyroid malignancies. Likewise, CLL, rather than to do with the treatment per se, inherently is associated with a higher risk of second malignancies. Now, with regards to the kind of cancer, skin cancer is something that has been mentioned in quite a few publications. Now, that doesn't mean that every patient will have to be referred to a skin specialist for a review. It's something about being vigilant and about being sensible. So if you're going out in the sun, make sure you're using sun protection. Make sure that you're examining yourself. If there is any doubt, like a suspicious mole, go and get it checked out by your GP. But it does not mean that you have to absolutely be paranoid about developing second cancers. But it's something to kind of have at the back of the mind that you're perhaps a bit more extra vigilant.
Good, thank you. Could you talk about the FLAIR trial and the criteria that patients need to pass before putting them on that trial? Would it be a first option, for example, for someone who is coming towards treatment to examine the FLAIR trial to see whether they would qualify?
The criteria is very, very easy from a physician's perspective. So any patient who we would have otherwise considered for intensive treatment with FCR-based chemotherapy should be eligible for FLAIR trial by virtue of that. So basically, what we're trying to say is those patients who are young, and by young I mean that perhaps in their, in their early 60s or up to 70s. I think anybody beyond 65, 67, I probably will get a bit anxious about giving them FCR. But otherwise, if they're otherwise young, they're fit, they don't have any other comorbidities, their cardiac and liver and renal and lung functions are all good, and you would otherwise have given them FCR. If FLAIR trial is open in your center, or if your FLAIR trial is open in a nearby tertiary center, I would absolutely recommend for them to consider eligibility and recruitment in that trial. Now, in FLAIR trial, originally when it was set out, there were 4 arms. There was your traditional FCR, then there was ibrutinib monotherapy, ibrutinib rituximab, and ibrutinib venetoclax. Now, the ibrutinib rituximab is closed for recruitment because they've recruited the numbers they needed to recruit. The 3 other arms are still open. Now, during the COVID pandemic, i.e. in March, April, May, we stopped recruiting to FLAIR trial, but those patients who were already on the trial were getting the treatment that they were on. But we have gradually reopened the FLAIR trial, so it's now open to recruiting again. So right. Yes, if you think that you are otherwise fit and kind of match all those criteria for FCR, and this trial has not been mentioned to you in your center, then I think you're more than justified to at least raise that question.
One final question before we let you go back to your clinic, which I know you're very keen to do. Acalabrutinib was made available on what I think you would call compassionate grounds during the pandemic. Could you discuss briefly some more about the treatment and about the access to the treatment?
So acalabrutinib is also a bruton tyrosine kinase inhibitor, the same group of drugs like ibrutinib. There was a phase 3 trial done called the Elevate trial, where they compared acalabrutinib to acalabrutinib obinutuzumab and obinutuzumab chlorambucil. And the data have shown that it produces higher response rates and higher progression-free survival in comparison to the obinutuzumab arm, obinutuzumab chlorambucil arm. So we know that this is an effective treatment, and it can be given to patients who are eligible for treatment. Now, it is not NICE approved at the moment, but because of the COVID pandemic, given that its phase 3 data was so promising, AstraZeneca, which was the company, set out an early access program scheme. And it was also in lines with the EAMS, which is the Early Access of Medicine scheme. And the two together made acalabrutinib available for patients who wanted to start treatment. And the positive side was that it had good data supporting it from a phase 3 trial. It was oral therapy, and you did not have to give patients immunotherapy, chemoimmunotherapy, as it were. You were avoiding patients having to come to the hospital. So in our trust, we have started about 2 or 3 patients on acalabrutinib, and I'm conscious that across the country, this has also been used. It does not have to be NICE approved. We're expecting an approval sometimes early next year. But if you're eligible for acalabrutinib, your consultant should be able to access it just simply by writing to the company.
Thank you very much, Dr. Chaudhuri. Fascinating discussion, fascinating answers, and we really appreciate your time today and previously to record. Thank you very much indeed, and we'll let you go back to your clinic.